Welcome to Pediatric Case Review. Today we present a comprehensive case-based review of Isovaleric Acidemia for general pediatricians. This is a rare but important organic acidemia caused by a defect in leucine metabolism. We will cover clinical presentation, pathophysiology, diagnostic workup, newborn screening, acute crisis management, long-term dietary therapy, pharmacological detoxification, prognosis, and complications. Let us begin. Question 1. A 4-day-old male infant is brought to the emergency department by his parents. He was born full-term via uncomplicated vaginal delivery with a birth weight of 3.2 kilograms. Over the past 48 hours, he has developed poor feeding, recurrent vomiting, and progressive lethargy. On examination, he is hypotonic and responsive to stimulation. His blood gas shows a potential of hydrogen of 7.18, bicarbonate of 10 milliequivalents per liter, and an anion gap of 24 milliequivalents per liter. What is the most likely underlying diagnosis? Option A, isovaleric acidemia. Option B, pyloric stenosis. Option C, glucose 6-phosphate dehydrogenase deficiency. Option D, congenital heart disease. The correct answer is option A, isovaleric acidemia. This neonate presents with the classic acute metabolic crisis that typically occurs between days 2 and 5 of life after initial protein feeding. The protein catabolism from feeding triggers accumulation of toxic metabolites. The key signs include vomiting, lethargy, poor feeding, and severe high anion gap metabolic acidosis. A classic clinical clue is the sweaty feet odor caused by isovaleric acid accumulation. This presentation closely mimics neonatal sepsis, so always include isovaleric acidemia in the differential for any neonate with unexplained metabolic acidosis and unusual body odor. Do not delay the workup. Question 2. A 12-day-old infant is brought to the emergency room with poor feeding, vomiting, and lethargy. During physical examination, the attending physician notices a distinctive, unusual odor emanating from the infant's body. What is the characteristic odor associated with isovaleric acidemia during acute metabolic crisis? Option A, maple syrup. Option B, mousy or musty. Option C, sweaty feet. Option D, cabbage-like. The correct answer is option C, sweaty feet. This odor is caused by the accumulation of isovaleric acid in the body. The isovaleric coenzyme, a dehydrogenase enzyme deficiency, blocks leucine breakdown, leading to accumulation of isovaleric acid, isovaleroglycine, and 3-hydroxyisovaleric acid. The isovaleric acid itself is responsible for the distinctive sweaty feet smell and is the primary cause of the odor. Isovaleroglycine and 3-hydroxyisovaleric acid are important urine markers used for diagnosis. It is important to note that this odor is not always present and may be absent in the attenuated form of the disease. Maple syrup odor is seen in maple syrup urine disease, mousy or musty odor in phenylketonuria, and cabbage-like odor in tyrosinemia. Question 3. A 6-day-old male infant is brought to the emergency room with 2 days of poor feeding and vomiting. He has a metabolic acidosis and a distinctive, unusual body odor. On examination, he appears very lethargic. Which neurological finding is most characteristic during an acute isovaleric acidemia metabolic crisis in this neonate? Option A, hypertonia. Option B, upward gaze deviation. Option C, clonus. Option D, generalized hypotonia. The correct answer is option D, generalized hypotonia. Profound hypotonia is a hallmark neurological sign of isovaleric acidemia during acute metabolic crisis. The infant appears floppy with reduced muscle tone throughout the body. This is associated with lethargy and decreased responsiveness to stimulation. Seizures may also occur in severe metabolic crises. The basal ganglia are particularly vulnerable to the toxic metabolites that accumulate in this condition. When evaluating a neonate with hypotonia and lethargy, check blood gas, glucose, ammonia, and lactate. If metabolic acidosis with an elevated anion gap is found, order an organic acidemia panel, including urine organic acids and plasma acylcarnitine profile. Elevated C5 carnitine should raise suspicion and prompt urgent metabolic specialist referral. Question 4. A 10-day-old neonate presents with poor feeding, vomiting, and lethargy. Newborn screening reveals elevated C5 carnitine. The metabolic team suspects isovaleric acidemia. Isovaleric acidemia is caused by a deficiency in which mitochondrial enzyme? Option A, isovaleric coenzyme A dehydrogenase. Option B, propionyl coenzyme A carboxylase. Option C, methylmalonyl coenzyme A mutase. Option D, phenylalanine hydroxylase. The correct answer is option A, isovaleric coenzyme A dehydrogenase. This is a mitochondrial enzyme located in the mitochondrial matrix. The deficiency is inherited in an autosomal recessive pattern and is caused by mutations in the isovaleric coenzyme A dehydrogenase gene. In normal leucine metabolism, leucine is first converted to alpha-ketosaccharoic acid through transamination, then to isovaleric enzyme A through oxidative decarboxylation by the branched-chain ketoacid dehydrogenase complex. When isovaleric coenzyme A dehydrogenase is deficient, isovaleric coenzyme A accumulates and is diverted to form toxic metabolites including isovaleric acid, 3-hydroxyisovaleric acid, and isovaleric glycine. These cause oxidative stress and inhibit the sodium-potassium pump, leading to neurological damage and metabolic acidosis. Question 5. A 10-day-old male infant presents with poor feeding, vomiting, and progressive lethargy. He was born full-term with no complications. On examination, he is hypotonic and difficult to rouse. A distinctive, unusual odor is noted. Metabolic workup is initiated. What is the primary toxic metabolite responsible for the clinical symptoms in isovaleric acidemia? Option A, ammonia. Option B, isovaleric acid. Option C, lactate. Option D, phenylalanine. The correct answer is option B, isovaleric acid. When isovaleric coenzyme A dehydrogenase is deficient, isovaleric coenzyme A builds up and is converted to isovaleric acid, which is the primary toxic metabolite. Isovaleric acid inhibits the sodium-potassium pump, causing neurological dysfunction and induces oxidative stress, leading to cerebral edema and seizures. Isovaleric coenzyme A itself causes mitochondrial dysfunction and metabolic acidosis. Free isovaleric acid also suppresses bone marrow, which can lead to pancytopenia. The body attempts to detoxify by conjugating isovaleric coenzyme A with glycine to form isovaleric glycine, and with carnitine to form isovaleric carnitine, also known as C5 carnitine, both of which are excreted in the urine. Question 6. A 5-day-old newborn has an abnormal result on routine newborn screening. The laboratory calls to report an elevated acylcarnitine species on tandem mass spectrometry. The infant currently appears well, feeding adequately, with no odor noted. Which acylcarnitine species is most likely elevated on tandem mass spectrometry newborn screening in isovaleric acidemia? Option A, C3 carnitine, also known as propionyl carnitine. Option B, C4 carnitine, also known as butyryl carnitine. Option C, C5 carnitine, also known as isovaleric carnitine. Option D, C16 carnitine, also known as palmitoyl carnitine. The correct answer is option C, C5 carnitine, which is isovaleric carnitine. This is the hallmark newborn screening marker for isovaleric acidemia. Newborn screening uses dried blood spots collected via heel prick at 24 to 48 hours of life. The sample is analyzed using tandem mass spectrometry, which detects elevated C5 carnitine. However, C5 carnitine elevation is not specific to isovaleric acidemia alone. 2-methylbutyrylglycinuria caused by mutations in the short-chain acyl coenzyme A hydrogenase B gene also shows elevated C5 carnitine. Pivotal carnitine exposure from certain antibiotics can cause a false elevation. Confirmatory testing includes urine organic acid analysis, plasma acylcarnitine profile, and molecular genetic testing of the isovaleric coenzyme A dehydrogenase gene. Question 7. A 7-day-old male infant was flagged on newborn screening with elevated C5 carnitine on dried blood spot tandem mass spectrometry. He appears well, feeding normally, with no acute symptoms. The metabolic team is consulted for next steps. Which test is most appropriate to confirm the diagnosis of isovaleric acidemia? Option A, sweat test. Option B, karyotype. Option C, renal biopsy. Option D, urine organic acid analysis. The correct answer is option D, urine organic acid analysis. This is the key confirmatory test after a positive newborn screening result showing elevated C5 carnitine. Urine organic acid analysis using gas chromatography mass spectrometry reveals markedly elevated isovaleroglycine, which is the most abundant and specific metabolite, along with 3-hydroxyisovaleric acid as a secondary marker. Plasma acylcarnitines support the diagnosis but do not confirm it alone. The full diagnostic pathway starts with newborn screening, then confirmatory urine organic acid analysis, then plasma acylcarnitine profile confirmation, and finally molecular genetic testing of the isovaleric enzyme ahydrogenase gene to identify biallelic pathogenic variants and confirm the diagnosis definitively. Question 8. A 3-year-old boy was identified on newborn screening with mildly elevated C5 carnitine. He has remained completely asymptomatic with no metabolic crises, normal development, and only subtle biochemical abnormalities on follow-up testing. His sibling had a severe neonatal presentation with profound acidosis. How do attenuated forms of isovaleric acidemia differ from the classic neonatal onset form? Option A, severity of biochemical changes. Option B, age of onset only. Option C, inheritance pattern. Option D, response to aspirin. The correct answer is option A, severity of biochemical changes. Attenuated isovaleric acidemia has milder biochemical markers and is often asymptomatic, discovered incidentally on newborn screening. Compared to the classic form, the attenuated form has a later or incidental onset, rare or absent metabolic crises, mildly elevated C5, carnitine and isovaleroglycine levels, mild missense gene variants rather than severe null or truncating variants, low neurological risk with usually normal development, and often does not require dietary restriction. Both forms share the same autosomal recessive inheritance pattern. Most attenuated cases found on newborn screening never develop symptoms, and diagnosis triggers lifestyle monitoring rather than aggressive treatment. Question 9. A 3-week-old male infant is brought to the emergency department with a 24-hour history of poor feeding, vomiting, and progressive lethargy. He was born full-term with an uneventful delivery. On examination, he is profoundly hypotonic, unresponsive to stimulation, and has an unusual sweaty, cheese-like body odor. Blood gas shows a potential of hydrogen of 7.10 with a metabolic acidosis. Ammonia is elevated. Isovaleric acidemia is suspected. What is the most critical immediate first step in management? Option A, initiate a high-protein diet to support anabolism. Option B, stop all protein intake and start intravenous glucose immediately. Option C, begin oral broad-spectrum antibiotics for presumed sepsis. Option D, refer for urgent surgical consultation. The correct answer is option B, stop all protein intake and start intravenous glucose immediately. The emergency protocol follows 6 critical steps. Step 1. Recognize the crisis by identifying vomiting, lethargy, metabolic acidosis, and the sweaty feet odor. Step 2. Stop all protein intake immediately, including breast milk and formula, for a maximum of 24 to 48 hours. Step 3. Start high-dose intravenous glucose using 10% dextrose at 1.5 times maintenance rate to suppress catabolism and provide an anabolic signal. Step 4. Increase carnitine at 100 to 200 milligrams per kilogram per day intravenously and glycine at 150 to 250 milligrams per kilogram per day. Step 5. Reintroduce protein gradually after 24 to 48 hours using low-leucine formula. Step 6. Monitor metabolic panels every 6 to 12 hours and consult a metabolic specialist. If hyperammonemia exceeds 200 micromoles per liter, consider sodium benzoate. Question 10. A 6-month-old boy with isovaleric acidemia was diagnosed through newborn screening and has remained metabolically stable. His metabolic dietitian is now designing his long-term nutritional plan. The primary goal is to restrict the dietary precursor responsible for toxic metabolite accumulation. The cornerstone of long-term nutritional therapy in isovaleric acidemia involves the restriction of which amino acid, Option A, valine. Option B, isoleucine. Option C, leucine. Option D, lysine. The correct answer is option C, leucine. Leucine is the branched-chain amino acid that is converted to isovaleric coenzyme A, which is the step blocked in isovaleric acidemia. Restricting leucine reduces the production of toxic metabolites and prevents metabolic acidosis and encephalopathy. High leucine foods that must be limited include meat, chicken breast, fish, dairy, eggs, and legumes such as lentils. Leucine-free medical formulas are used to provide essential amino acids without leucine. Examples include the leucine analog formula, Isovaleric, branched-chain amino acid-free formula number 2, and homocystinuria anamix as adjunct support. A critical clinical pearl is that natural protein is not fully eliminated. Small amounts are maintained to meet essential amino acid needs. Leucine is titrated, not zeroed. Question 11. A 3-month-old infant with confirmed isovaleric acidemia is being established on long-term outpatient management. His metabolic team plans to start pharmacological detoxification therapy to conjugate the toxic isovaleric coenzyme intermediates and promote their urinary excretion as non-toxic compounds. Which of the following supplements are used for this purpose? Option A, vitamin C and vitamin D. Option B, iron and folate. Option C, zinc and selenium. Option D, glycine and L-carnitine. The correct answer is option D, glycine and L-carnitine. These two agents work through different detoxification pathways. L-carnitine conjugates with isovaleric coenzyme A to form isovaleric carnitine, which is the C5 carnitine species that is excreted in urine. Glycine conjugates with isovaleric coenzyme A to form isovaleric glycine, which is also excreted in urine. Both pathways reduce the level of free isovaleric acid and reduce toxicity. The standard dose of L-carnitine is 50 to 100 milligrams per kilogram per day given orally or intravenously. Glycine is dosed at 150 milligrams per kilogram per day orally. During acute metabolic decompensation, L-carnitine can be increased up to 200 milligrams per kilogram per day intravenously. Both agents are used together for maximum detoxification efficacy. Question 12. A 4-year-old boy with isovaleric acidemia is attending his annual neurodevelopmental follow-up. He was diagnosed through newborn screening at 5 days of age and has been managed since then. His parents ask about his long-term prognosis and what factors most influence his cognitive development. What is the most significant factor determining long-term neurocognitive outcomes in patients with isovaleric acidemia? Option A, timing of diagnosis. Option B, eye color. Option C, birth weight. Option D, geographical location. The correct answer is option A, timing of diagnosis. Early detection through newborn screening combined with crisis prevention is the strongest predictor of normal neurodevelopmental outcomes. Infants detected through newborn screening who never experience a metabolic crisis have approximately 85% normal development. Those detected through newborn screening but who had crisis episodes have approximately 55% normal development. Clinically detected symptomatic cases have only approximately 30% normal development. Repeated decompensations increase the risk of basal ganglia injury, movement disorders, and cognitive delay. Long-term complications include intellectual disability, growth retardation, osteoporosis from prolonged dietary restriction, and rarely acute crisis in adulthood triggered by catabolic stress. Early newborn screening detection plus strict dietary adherence results in near-normal life expectancy and quality of life. Before we conclude, I want to share with you an exciting resource. Pediatric Case Review is now available on Patreon. In this community, you will find all our videos organized by body system, so you can easily access and navigate through all lectures in one place. All presentations used in the videos are also available as downloadable images, perfect for offline review and practice of all questions. This is premium case-based clinical education built specifically for general pediatricians. For details on how to subscribe, simply comment below in this post, and we will message you directly. We respond to every message. Let us review the key takeaways from today's lecture on isovaleric acidemia. First, newborn screening is critical. Elevated C5, carnitine on newborn screening should trigger immediate metabolic workup. Second, the sweaty feet odor is a classic clinical clue during acute metabolic crisis caused by isovaleric acid accumulation. Third, C5, carnitine, which is isovaleric carnitine, is the primary diagnostic marker on newborn screening. Fourth, a low leucine diet is the cornerstone of long-term management to reduce toxic metabolite load. Fifth, the emergency protocol saves lives. Stop protein, start intravenous glucose, and give carnitine plus glycine supplementation. Sixth, lifelong monitoring is required because metabolic surveillance continues into adulthood and patients should never be discharged from care. Thank you for joining Pediatric Case Review. We hope this comprehensive review of isovaleric acidemia has been informative and clinically valuable. Please remember that these lectures are for educational purposes only and do not constitute medical advice. Always consult current guidelines and specialists for clinical decisions. If you found this lecture helpful, please follow our channel for more case-based clinical lectures. If you have any questions or feedback, please comment below. We read every single comment. Thank you and see you in the next lecture.